A very good evening and warm welcome to my next session of physiology. In this part 8 of physiology, we shall be discussing thyroid gland. In my last class, I discussed in detail the importance of calcium metabolism, calcium homeostasis we call it, calcium metabolism or calcium homeostasis. In that we discussed first what are the different actions of parathormone, calcitonin and vitamin D, and how are they controlling the calcium and phosphate metabolism in our body. We shall be discussing that also in this class as a summary in a different manner so that you understand it well, but at the end of the session. To begin the session today, I'll be discussing the importance of the hormones which are secreted in the thyroid gland. I'll discuss how are these hormones synthesized, how are these hormones transported, after transport how are these hormones working, and what are the actions of this thyroid gland hormones. So please remember that in human beings, thyroid hormone is very essential to bring about normal growth and maturation. Many patients ask us in our clinics, sir, what is the function of thyroid gland? Why is my thyroid hormone abnormal? Many a times doctors are unable to give perfect answer to their patients because most of the doctors don't themselves understand what is the important function of thyroid gland. So please remember that thyroid gland is required every second of your body. Your body is under growth. Your body is under repair and growth mechanism. Normal growth and maturation of various cells, tissues, organs is brought about by action of thyroid hormones. The basic action of thyroid hormone is anabolic hormone. Anabolic means constructive. Anabolic means to synthesize. So thyroid hormone like insulin is an anabolic hormone, whereas other hormones which we discussed in our class last time, the epinephrine, the cortisol, those were catabolic hormones. The glucagon, those were the counter-regulatory hormones, hormones which are secreted under stress. So I discussed in detail in my last videos. If you want, you can go back and listen to it. Here, thyroid hormone, it's a major anabolic hormone of our body, and the development of the synthesis and development of the hormones present in the thyroid gland, it depends on iodine metabolism or iodine intake in your diet. Iodine intake or iodine metabolism in your diet. Iodine in the form of iodide. This is the dietary active compound of iodine, iodide, that is represented as I minus. Iodide. We require around 500 micrograms of iodine per day for normal metabolism of thyroid hormones. In pregnancy, this requirement is increased. In pregnancy and lactation, this requirement is increased. Here the 150 micrograms is the minimum recommended dose to maintain normal thyroid function. This minimum maintained dose of 150 micrograms of iodine, this is very much increased in pregnancy. The demand is very much increased in pregnancy, and we have seen that the thyroid gland hormone disorders are very much manifested during pregnancy more than any other physiological condition of our body, right? So the functional unit of thyroid gland is thyroid follicle. Thyroid follicle. Like we have functional unit of kidneys as nephron. Functional unit of central nervous system is neuron. Here, the functional unit of thyroid gland is the thyroid follicle. This thyroid follicle has got a lumen, all right? So follicle is something like this. Thyroid follicle, it has got a central lumen like this. Peripherally, it has got tall columnar cells like this. This is a structure of a thyroid follicle. Each of these cells will have a basal nucleus, a round basal nucleus. The central portion of this follicle is filled with what is known as colloid. So this part is colloid. Remember that this colloid is rich in a protein called as thyroglobulin. This the colloid is rich in a protein called as thyroglobulin, and the cells of the thyroid follicle secrete hormone. They store the hormone. They store the hormone in the central portion, that is colloid. In the colloid we have got thyroid hormones T3 and T4 and the thyroglobulin protein. This lumen is surrounded by the follicular cells. The colloid is surrounded by the follicular cells, which synthesize and release the thyroid hormones. So what's happening is, say suppose this is the thyroid gland. What's happening is, iodine enters into the thyroid gland in the form of iodide, and here we have got various follicles, whole of the gland. I'm just drawing this for representation purpose. All right, we have got whole of the gland is full of follicles. Each follicle traps the iodide. This follicular lumen, each follicle, again if you expand this follicle, looks something like this. So it has got a central lumen like this, and peripheral cells like this surrounded by these cells, tall columnar cells. With basal nuclei, round nuclei. All right, and the central colloid. Colloid full of thyroglobulin, I already told you. So each of these cell synthesizes the T3 and the T4. The thyroid follicle cells synthesize T3 and T4. They initially synthesize it, store it, secrete it, then they release it into the colloid. Around 60 micrograms of hormone, that is T3 or T4, is synthesized and released, secreted per day. All right, per day. So now let us see how is the synthesis of the hormone occurring. The synthesis of this hormone requires an understanding of what is known as iodination, the oxidation, iodination, and coupling of tyrosine. Tyrosine is an amino acid. In our biochemistry class, I will go in much details of this. But please remember, say suppose this is the thyroid follicular cell. This is the thyroid follicular cell, and thyroid follicular cell, what happens is, say suppose this is the extracellular fluid and this is the follicle cell, and this part is the follicular lumen. All right, somewhere here we have got follicular lumen like this. So this part is follicular lumen, right? So what's happening is, iodine, in the form of iodide, it is entering into the follicular cell, and in exchange with sodium. So we have got sodium iodide symport, So sodium and iodine, they enter together. For every two atoms of sodium, one iodine in the form of iodide enters, and this iodide is carried in the follicular lumen. From here, it should enter into the lumen with the help of an enzyme called as peroxidase. Peroxidase is an enzyme, all right, thyroperoxidase or peroxidase enzyme. From here, iodine is trapped and iodine enters into the lumen. Now the iodine is undergoing oxidation into the lumen. It undergoes oxidation and loses one electron, and it is combining with the tyrosine to form what is known as monoiodothyronine. Monoiodotyrosine or thyronine. Two molecules of monoiodothyronine combine and form diiodothyronine. Diiodothyronine or diiodotyrosine. One molecule of diiodo and one molecule of monoiodothyronine combine to form T3, triiodothyronine. So this is how T3 is formed. And if two molecules of diiodothyronine combine, it results in formation of T4. It results in the formation of T4. So T3, T4, the monoiodothyronine and the diiodothyronine, these are all the molecules, these are all the synthesized products present in the lumen. They combine, they are coupled with what is known as thyroglobulin. They are coupled with a protein called as thyroglobulin. They are coupled with a protein called as thyroglobulin. This point you need to understand. So this is all is the steps in the synthesis of thyroid hormone. I'll quickly talk about these steps again. What happens first? The first is iodide uptake or iodide transport. So in this, the first step, if you see, the iodide transport, which is occurring here, the iodide transport. Iodine transport is via the sodium iodide, sodium potassium pumped, which is powered by sodium iodide symporter channel present in the basal membrane or basolateral membrane of the follicular cell. This pump admits 2 sodium along with 1 iodide. The iodide within the cell is 25 times that of the plasma. So we have got the follicular cells are very, very rich in iodide. They are 250 times more than the plasma, not 25. It is 250 times more than the plasma. This pump is usually blocked by thiocyanate and percolate. Now these are the drugs. These are the drugs which block the first step, that is iodine trap or iodine transport. I'll discuss this again when I'll be dealing with pharmacology. I'll discuss again, right? The 24 hours iodine uptake by the thyroid gland is directly proportional to the thyroid function. The uptake is directly proportional to the thyroid function. All right, please remember this fact. Next, what happens is a high molecular weight protein is synthesized. This is called as the thyroglobulin. Thyroglobulin is a very high molecular protein. It is a coupling protein. It is synthesized. It is glycosylated. Where is it? In the endoplasmic reticulum. So thyroglobulin synthesis is the second step. Thyroglobulin synthesis. Thyroglobulin synthesis is the second step, and it is synthesized in the endoplasmic reticulum. In the endoplasmic reticulum, then from here it is packaged into vesicles. multiple vesicles, and then it is transported to the Golgi apparatus. These are the cell organelle which are handling this protein. Then the thyroglobulin enters into the lumen from Golgi apparatus. It is entering into the lumen of the follicle. So this is about the second step. First step was the iodine transport. Second step is the thyroglobulin synthesis. Third important step we shall be talking about the oxidation. Oxidation of iodide to iodine. So here an enzyme called as thyroperoxidase enzyme plays a very, very important role. Thyroperoxidase. See, these enzymes are actually very important to understand autoimmune hypothyroidism. Autoimmune type of thyroidism, either hypothyroidism or any form of thyroid disorder. So you should remember what is the function of this enzyme is the thyroperoxidase enzyme denoted as TPO. Its function is it helps in oxidation of the iodide. Where is it present? It is present at the apical border. Of the follicular cells. Apical border of the follicular cell. And it catalyzes the reaction of the oxidation of iodine. We call it iodination and coupling. Alright. So two functions of this enzyme, iodination and coupling. Iodination and coupling. Alright. Next. So what is coupling? Let us try to understand. So peroxidase, it is promoting coupling. I'll discuss this as a separate step. So peroxidase is actually helping in coupling. The fourth step. It is promoting coupling by iodination of tyrosine. It couples what? Iodine plus tyrosine. This is what is a coupling. And couples it with the thyroglobulin molecule. Thyroglobulin molecule. So what is formed is, if single iodine couples with tyrosine, you are calling it as monoiodotyrosine. Diiodotyrosine in case of two iodines. One monoiodo and one diiodo combine to form the triiodotyrosine or thyronine. We call it T3. Two molecules of diiodothyronine combine to form T4. So the monoiodotyrosine, the diiodotyrosine, the T3 and the T4, all these combine, they get coupled to whom? They get coupled to the thyroglobulin. This is what is a function of thyroperoxidase. But when iodine becomes very, very little or deficient in our body, what happens is the production of T3 increases. Please remember, when iodine is deficient, it results in the synthesis of T3. So if iodine is deficient, it increases T3 production. If iodine is abundant, it increases T4 production. Alright. T4 and T3. This is the importance of coupling. So how are the hormones stored? Let us try to understand. The most important storage is iodination, the thyroglobulin in the follicular lumen. It is stored for 2 to 3 months. We have got reserves for 2 to 3 months. 2 to 3 months reserves. So body has got mechanism to store the iodine, the iodinated thyronine, that is the thyroxine hormone, for 2 to 3 months. And whenever the need increases, it can synthesize. That is a stimulus to synthesize more. Now let us try to understand how is this hormone secreted, secretion of the hormone. This is all synthesis of the hormone. Let us try to understand how is this hormone secreted. So to demonstrate secretion, we need to understand certain process like pinocytosis. Pinocytosis means what? Pinocytosis means it is the follicular colloid is there, right? This follicular colloid, it is taken back into the follicle by endocytosis. This is called as pinocytosis. All right. The endosized follicular material, it fuses with lysosomes. When it fuses with lysosomes, which is transported towards the basal, now it is transported toward the basal layer of the cell. Here what happens, proteolysis of the thyroglobulin occurs and then secretion occurs. All right. For if you are unable to understand, I will repeat again. So what's happening is, so we have got, I told you, I want to remind you that this is the cell, the colloid cell, and this part is a colloid. Say suppose this is the lumen filled with colloid. So in the colloid, what's happening is the thyroglobulin. So we have got T3, we have got T4, we have got monoiodothyronine, the diiodothyronine, which are coupled with what? Thyroglobulin protein. All right. This part enters into the apical border of the epithelial cell or follicular cell. This process is called as pinocytosis. After this, what happens is the T3, the T4, the monoiodothyronine, the diiodothyronine, all these undergo fusion with the lysosome. Fusion. Because of the lysosomal activity, proteolysis is promoted now. So it undergoes proteolysis. Proteolysis means protein breakdown. So which is the protein here? Proteolysis of the thyroglobulin protein. Once there is protein breakdown, what will happen? Now the thyroglobulin gets separated from the monoiodothyronine, thyroglobulin gets separated from the diiodothyronine, thyroglobulin gets separated from the triiodothyronine, thyroglobulin separated from the tetraiodothyronine. All this separation occurs, and after this what happens is there is deiodination. Deiodination, and once there is deiodination, iodine is also getting separated. Iodide gets separated from thyroxine, from the thyronine and thyroxine, and T3 and T4 are released into the circulation. T3 or T4 are released into the circulation in the plasma. They enter into the blood here. It's a very, very important step here. So hope you are able to understand. This is how the thyroid hormone secretion occurs. All right, I repeat again. First step is pinocytosis, somewhere here, if you can understand, with a different color. I'll number it. First step is pinocytosis. Second step is fusion. So this part, fusion with the lysosome and action of lysosome. The third step of secretion is proteolysis of thyroglobulin. The fourth step is deiodination. Fourth step is deiodination. So the secretion of T3 and T4 into the blood, please remember, it's a very, very important process. The ratio is maintained always. The T4 to T3 ratio is always maintained high, around 20:1. For every 20 molecules of T4 secreted, 1 molecule of T3 is secreted. So we have an enzyme called as 5-mono-deiodinase. 5-mono-deiodinase. This enzyme, which is found in peripheral tissues, this enzyme in an iodine deficient state, it converts T4 to T3. it deiodinizes T4 to T3. All right. So along with this thyroid hormone, small amount of thyroglobulin is also released into the circulation. And as the thyroglobulin is released into the circulation, the more number of thyroglobulin states that this person, like for example, is having some disease of the thyroid, like thyroiditis or goiter or a cancerous tissue or a neoplastic tissue. Once you remove this cancerous tissue, the thyroglobulin levels come down, should come down. If it does not come down, it indicates that there is some ectopic thyroid which is producing the thyroglobulin. So this is how we differentiate in a diseased pattern, right? This deiodinase enzyme is a microsomal enzyme. The function of this deiodinase enzyme is to remove iodine, and it removes iodine from the iodinated thyronines. Please remember, it removes iodine from the iodinated tyrosines like monoiodotyrosine, diiodotyrosine. All right. The except that the 5-monoiodinase, the 5-mono-deiodinase, which is found in the peripheral tissue, deiodination in by other enzymes apart from 5-mono-deiodinase, the other deiodinases enzymes, they are involved in deiodination of monoiodothyronine and diiodothyronine. All right. Now let us try to understand how are the thyroid hormone transported into the blood. I summarize. First we started understanding of synthesis, then we started understanding of secretion. Now let us start the understanding of transport. Now physiologically there is an equilibrium that is maintained between the bound form of hormone, thyroid hormone T3 and T4, and the free form. There is always a equilibrium maintained. How is this equilibrium maintained? Say suppose this is a molecule of thyroglobulin, and to this we have got either T3 attached or T4 attached. This is the bound form. So there is always a equilibrium maintained between the free T3 T4 and bound T3 T4. We have got 99% of the hormone is in bound form and only 1% of the hormone is in free form. And this 1% of the hormone which is in free form is responsible for various physiological activities. So what are the other proteins to which the thyroglobulin bind apart from the thyroid hormone bind apart from thyroglobulin? We have got transthyretin. We have got albumin. So these are the other proteins to which the T3 and T4 are bound. The T4 has got very, very high affinity for binding proteins. All right. Sometimes rare congenital deficiencies, sometimes rare congenital disorder occur which show excess of thyroid binding globulins, and this affects the free T4 drastically. And in normal individuals, when you compare with normal individual, the free fraction is around 1%. But when you compare with any condition where thyroglobulin proteins are very, very high because of rare congenital deficiencies, so in such cases, obviously, the free form of hormone comes down. Please remember that T4, I already told you, I repeat it again, the T4 it has got a very, very high affinity to the binding proteins when compared to T3. So it binds more tightly to the proteins than with T3. So who is very easily removable or easily available for the tissues? The one which is less bound to the proteins, the one which is less tightly bound to the proteins is freely available to the tissues. So who has got half-life? Please remember, the higher half-life is for T4 because it is bind to the protein very strongly. It has got strong affinity to the proteins. Hence, higher half-life. Higher half-life. I don't understand. So in according to physiology textbooks, give me 5 minutes of break, please, for Azan. Welcome back after the short break. So please remember that in certain physiology textbooks, the T4 half-life is given around 1 week. So 6 days. Different books are giving different. But please remember, it completely depends on the metabolism of this thyroglobulin proteins. And we all know that T4 has got very high affinity. T4 binds tightly to the proteins. It has got very high affinity. Hence, it has got a greater half-life. And the most circulating form of thyroid hormone is again T4. So T4 has got a greater half-life. T4 has got strong affinity. These are the properties. And it is the most circulating form. If you remember my last class, I told you what is the most circulating form of vitamin D. It is the 25-hydroxy vitamin D. Yesterday, I told you in the class. So here T4 is the most circulating form of vitamin D, right? And T3 has got a half-life of around 1 to 2 days. T3 has got a short half-life. The amount of circulating thyroid hormone is about 3 times the amount normally secreted by the gland each day. So each day, I told you 60 micrograms of the hormone is secreted. Every day, the amount of secretion, if you compare with amount of circulation, the circulating amount is 3 times more than the secreted amount. Thus, the circulating protein bound thyroid, the circulating form, the circulating form is not free. It is bound to thyroglobulin. Hence, who is binding it and keeping it as a significant reserve in our body? It is the thyroglobulin. Hence, the levels of thyroglobulin determine the level of the hormones. Please remember this point. Now, we should understand how are these hormones activated and degraded. So, how is this activation of the hormone and degradation of hormone is occurring? Activation and degradation of hormone. It is involved with the help of enzyme 5-mono deiodinase. 5-mono deiodinase. What happens is that T3 and T4, they bind to the same nuclear receptor, but T3 binds to the receptor 10 times more stronger than T4. So T3 and T4, say suppose this is the cell, we have got, this is the nucleus, so this is the nucleus we have got, so this is the nucleus, so we have got nuclear receptors here. I'll draw it with some other color. So these are the nuclear receptors here, say suppose the nuclear membrane receptors. So T3 binds more strongly, T3 binds more strongly to the nuclear receptors, 10 times more affinity to the nuclear receptors. Because of this greater affinity, T3 is the most active form of the thyroid hormone. If they ask you what is the most active form of thyroid hormone, it is a T3, most active form. It has got a shorter half-life, but it is very active because its affinity to nuclear receptor is very high. Hence, it is the most active form of thyroid hormone. There are many target tissues. So if it is the more active form, we have got abundant T4. Now we have to convert this T4 to T3, is it not? So that action occurs. We have got in our peripheral tissues, we have got abundant sites, target cells, wherein T4 gets converted to T3. We call it activation of hormone. Thereby, locally, the tissues can handle this hormone and they can self-activate the hormone by themselves. The T4 is getting converted to T3. Which is more active? T3 is more active. Which is less active? T4 is less active. Which is high in number? T4 is more high in number. Which is less in number? T3 is less in number. Which has got long half-life? T4 has got long half-life. Which has got less half-life? T3 has got less half-life. Who is more protein bound? T4 is more protein bound. Who is less protein bound? T3 is less protein bound. Who has got more affinity to the nuclear receptors? T3 has got more affinity to the nuclear receptors. Who is more active? T3 is more active. So what happens is T4 needs to be getting converted to T3. T4 should be getting converted to T3. This process is occurring locally. T4 gets converted to T3. And this process is occurring locally. We call it activation of the hormone. What happens? Most of the circulating T3 is derived from peripheral conversion of this T4 to T3. Most of the circulating T3 is derived from peripheral conversion of T4 to T3. And how is this occurring? Example, in the liver, in the kidney, in the skeletal muscle, where we require 24 hours, we require the change of the activity of thyroid, active thyroid hormone, that is a T3. So how is it occurring? By the activity of enzyme 5-mono deiodinase. This process you are calling it as activation. This process you are calling it as activation, more active form. All right. Sometimes what happens is T4 is acted upon by some other pathway, some other enzyme, and it results in formation of a reverse T3. What is this reverse T3? This reverse T3 is a product of T4 conversion by an enzyme called as monodeiodinase. Other type of monodeiodinase enzymes. Other forms of monodeiodinase enzyme result in the formation of reverse T3. This is a molecular change in T3 and we call it degradation pathway. To understand this further, there are certain clinical states which are associated with conversion or reduction in the conversion of T4 into T3, and with an enhanced some condition wherein active form of T3 is not formed, but the reverse T3 is formed. We call it low T3 syndrome. Low, obviously T3 levels are low, so low T3 syndrome. This low T3 syndrome, it is termed as degradation. In these states, for example, person is fasting, patient is in medical stress, medical emergency, or some surgical process is going on, some catabolic state in the body, some cancerous condition or catabolic, so patient is taking certain harmful drugs, harmful medications. Because of this, what will happen is an excessive secretion of cortisol. More and more stress means more cortisol, and more cortisol means more reverse T3, and patient develops reverse T3 syndrome. So as a result, what will happen? As a result, there is a reduction in the metabolic rate because active form of T3 is not formed. Some reverse T3, which is chemically dissimilar to T3, is formed, and because of this, patient undergoes the basal metabolic rate decreases. The patient cannot store his energy sources. Patient develops lack of ATP, and he develops weakness, lethargy, catabolic state prolongs. So because of this, what happens is, give me a short break. I got a call. Give me a short break. Thank you so much. Welcome back. So this low T3 syndrome, what happens as a result is metabolic rate decreases and patient is under metabolic stress. As the underlying condition becomes more and more severe, what will happen is initially the T3 levels are low, but later on all the T4 which is present is getting converted to reverse T3. So T4 levels also come down. Later on T4 levels also come down. So this is all about activation and degradation of T4 into T3 and reverse T3. Now let us discuss, time has come to discuss the physiological actions of the thyroid hormone. What are the actions of the thyroid hormone? Physiological actions of the thyroid hormone. Let us discuss them. The thyroid hormone in many tissues, they are important indicators, or they are, what do you say, they are important regulators of metabolic rate. That is the first and foremost point. They bring about all the cellular processes, the important cellular processes. They are executed properly because of the thyroid hormone. What happens is not even one process, multiple processes. Not even, I can't say that only one process is executed and others are inhibited. No, it's an anabolic hormone. It is a constructive hormone. So what happens is, actually thyroid helps in bringing about various metabolic processes at one go, at one time. So it, like a multitasking it is doing, and this is evidenced by, we call it increase in BMR. The first and foremost physiological action is metabolic rate. Evidence of this point which I am saying is by the fact that thyroid increases oxygen consumption of the tissues. Oxygen consumption of the tissues. Because of thyroid hormone, oxygen consumption of the tissues is increased. Second thing is heat production. Heat production of the tissues is also increased. So these 2 points help us to understand that the underlying process in the cell is very, very fast. Thyroid hormones, they increase the activity by a protein, by a membrane bound protein called as sodium potassium ATPase. The enzyme channel which is required, and it helps in not only increased oxygen consumption but underlying energy generation, that is ATP production pathways, various ATP production pathways. The increase in metabolic rate, that is by thyroid hormone, this is studied by injecting a small dose of T4 into the patient. You inject a small dose of T4 into the person, and you check for the latency several hours. We can see the changes for that last as long as 6 days. As long as 6 days, the patient's metabolic rate was increased. All right. The thyroid hormones are very much essential for the normal nervous tissue activity. So for the CNS activity, for the brain activity, the thyroid hormone is very, very essential. The thyroid hormone brings about the normal menstrual cycle. So menstrual cycle physiology I'll discuss in my subsequent classes, which is very interesting to understand. Other diseases also based on menstrual cycle physiology can be addressed to and can be understood, and patient can be very much easily treated. Who is bringing about the normal menstrual cycle? It is a thyroid hormone which is responsible for normal menstrual cycle, and thus thyroid hormone has got a direct impact on the infertility if patient is suffering from. So many a times you have seen infertile people, and we treated the person with thyroid hormones if their thyroid was low, and patient was showing significant improvement. Now, thyroid, the second important point is, apart from basal metabolic rate, first was basal metabolic rate. Second is growth, body growth and maturation, especially that is seen in children and adolescents and pregnant. The growth and maturation in the absence of thyroid hormone production, it was found that in the perinatal period, in the intranatal life, perinatal life, what was happening is central nervous system maturation was not occurring, synapse is not properly developed, the dendritic processes are not properly developed, and the child developed mental retardation, especially in case of neonatal hypothyroidism. In case of neonatal hypothyroidism, mental retardation, a retarded mental growth because of absence of synapse, failure of production of dendrites, these are the parts of the nervous tissue. These neuronal changes are irreversible and they lead to what is known as cretinism. Cretinism is deficiency of thyroid hormone in children. Cretinism. All right, irreversible changes. But if replacement therapy is started, this is the most common reversible form of mental retardation in children. Most common reversible form of mental retardation. I am saying irreversible because if it is untreated, if it is treated, it is most common treatable form of mental retardation or reversible form of mental retardation. But the thing is, you need to start thyroxine at a very, very early age. You need to detect it very quickly, and you need to detect it very quickly and start early age. That's the reason why in developed countries, heel prick samples of every newborn child, every child who is born, heel prick samples are taken, and these heel prick samples, they check for TSH level. Blood TSH level is checked. If the TSH levels are high, it is termed as hypothyroidism, and immediately thyroxine treatment is started, especially if mother is also suffering from this disease. So this is the second important point. The growth and maturation of both skeletal system and also central nervous system is brought about by the thyroid hormone. The third important point is lipid metabolism. Thyroid has got direct effect on lipid metabolism. What is this direct effect on lipid metabolism? This thyroid hormone, it helps in the conversion of the cholesterol, it accelerates the cholesterol clearance from the plasma. Hence, a person who is having deficiency of thyroid hormone, he presents with hyperlipidemia, hypercholesterolemia. Cholesterol is very much increased. What happens is you do a lipid test to the patient and you find high cholesterol. You don't do thyroid test and you simply start lipid lowering agent. What are you treating? You are treating only his symptom or one particular point, but you are not treating the underlying disease. The underlying disease in this patient I am discussing was actually thyroid deficiency. If you would have checked the thyroid TSH and then treated the underlying thyroid deficiency, probably his or her cholesterol levels automatically come down. So instead of jumping into conclusion and starting lipid lowering drugs, always cross check. One sample of thyroid hormone test should be done in any patient who presents with lipid metabolism disorder. So in some people, what will happen is patient presents with night blindness. Patient presents with yellowish discoloration of the skin called as carotenemia, especially in people who are on vegetarian diet. So yellowish discoloration of the skin. In vegetarians, you call it carotenemia, and this is because the thyroid hormone is responsible for conversion of carotene to vitamin A. This is seen in patients who are deficient of, so this process does not occur, the vitamin A conversion does not occur, and patient develops yellowish skin. Carotenemia, yellowish skin because of hypothyroidism. This is the third important point. Next, thyroid hormones are involved in the metabolism of carbohydrate. I told you it increases oxygen consumption, it increases glucose absorption from the intestine. So this is what is the importance in carbohydrate metabolism. So next important, the fourth important point is carbohydrate metabolism. The carbohydrate metabolism. Now, does the thyroid hormone affect heart? Yes. What are the cardiac? So what is the carbohydrate metabolism I told you? Increased glucose absorption or reabsorption from the intestine, from the small intestine. Next, what is the cardiovascular effect? Cardiovascular effect of thyroid hormone, let us try on. The thyroid hormone has got positive inotropic effect on the heart. What does that mean? It increases the force of contraction. It has got a positive chronotropic effect on the heart. What does that mean? Increase the heart rate. So both force of contraction is increased. So increases force of contraction and increases the heart rate. What does that mean? It increases the cardiac output. So if thyroid hormone is deficient, force of contraction comes down. Thyroid hormone is deficient, heart rate comes down. In hypothyroidism, patient may present with bradycardia. Why bradycardia? Because thyroid hormone always has a positive chronotropic effect. It increases the contractility by increasing the affinity to beta adrenergic receptors. Beta adrenergic receptors. So we gave drugs called as beta blockers to the patient. If patient is having thyroid disorder, that is hypothyroidism, in such people, the affinity to beta receptors will be low and only small amount of beta blockers will bring about a good change. Exactly opposite occurs in hyperthyroidism. So we need to understand that the affinity of beta adrenergic receptors on the heart, it is a function of thyroid hormone. Thyroid hormone increase the affinity of beta adrenergic receptors, activity of beta adrenergic receptors, which are highly sensitive to the adrenergic amines, that is catecholamine. All right. Now here, because of increase in inotropic action, increase in chronotropic action, the cardiac output is increased. Thyroid hormone also acts on the SA node. Because thyroid hormone is acting on the SA node, it increases the heart rate. Thyroid hormone acts on the muscle, hence it increases the cardiac output. It increases the stroke volume and heart rate, both. It increases the stroke volume and the heart rate, hence increases the cardiac output. Product of stroke volume and heart rate is cardiac output. I told you already in my cardiology class. So here the systolic blood pressure increases due to increase in the stroke volume. Diastolic blood pressure decreases due to decrease in the peripheral resistance. So I repeat, thyroid hormone increase the systolic blood pressure and decrease the diastolic blood pressure. Why? because systolic blood pressure is increased because of increase in stroke volume. Diastolic blood pressure is decreased because of increase in the peripheral resistance. So because of decrease in the peripheral resistance, I was right actually. So thyroid hormone in the normal range, it gives optimum cardiac performance by all these effects. Please remember that thyroid hormone is responsible to maintain ventilatory drive during hypoxia. Thyroid hormone helps in gut motility, hence patient may develop constipation if thyroid hormone is less. Hypothyroidism people are associated with increased prolactin. This is because the thyrotropin hormone from the hypothalamus, the thyrotropin hormone in the hypothalamus, it not only stimulates the production of TSH by the pituitary, it also stimulates the production of prolactin. So if some patient who has got high levels of TSH, for him high levels of prolactin is a rule sometimes, all right, and you need to you treat the TSH and automatically the prolactin levels come back to normal, all right. So if this is the hypothalamus, and from here the stalk of the pituitary, and this is the pituitary gland, say suppose, so this is the hypothalamus and this is the pituitary gland, and somewhere here we have got the thyroid gland, somewhere here we have got the thyroid gland. So what happens is the hypothalamus releases thyrotropin releasing hormone which acts on the pituitary gland to release TSH. From here TSH comes, and this TSH acts on the thyroid gland to produce what? T3 and T4. T3 and T4. What is the usual ratio of T4 to T3? 20:1. 20:1. All right. It might be more also. So what happens is the presence of T4 and T3 into the circulation. The presence of T4 and T3 into the circulation, it gives a negative feedback onto the pituitary. It gives a negative feedback onto the hypothalamus to decrease the TSH level. Exactly opposite happens when there is low T3 and T4. Low T3 and T4, the TSH levels are very, very high. So this is the mechanism of regulation of TSH and regulation of thyroid. So as long as the free circulating T4 remains normal, it does not affect the TSH production, but TSH production increases. ये हिल रहा, मेरी class disturb हो रही. Don't touch here, please. So T3 and T4, they are responsible for negative feedback on the pituitary and hypothalamus. So if T4 and T3 levels are normal, it does not affect the TSH production. But if T3, T4 are low, it significantly increases the TSH production, and hence the thyroid gland secretes more and more T3 and T4. So this is what is the overall regulation of the thyroid gland, overall regulation of the T3, T4, and its feedback negative mechanism, negative feedback on the hypothalamus and the pituitary gland. Sometimes what happens is the TSH tends to rapidly increase sometimes. So the synthesis, the degradation and iodine trapping, the thyroglobulin synthesis, the exocytosis, I told you all these points, right? That is synthesis and release of thyroxine gland. So TSH actually rapidly improves the rate of these steps, and thus the hormone effects are brought very, very quickly. So in patients who suffer from certain disorders, we need to check whether the serum TSH levels are high or low. Serum TSH levels will help us to determine whether the patient is suffering from hypothyroidism or hyperthyroidism. Say suppose if TSH levels are high, what does that mean? It means that patient is having low levels of T3 and T4, which are causing high serum TSH because of negative. Hence, this person is suffering from hypothyroidism. Now, hypothyroidism can be primary in endocrinology. in medicine I'll teach you again. If the disease is in thyroid gland, we call it primary. If the disease is in pituitary, we call it central or secondary. All right, some other cause we call it secondary or tertiary or whatever it is. So here we need to check serum TSH levels. Another important test that we do is free T4. What is free T4? Free T4 is an unbound T4, is it not? The free T4, which is easily available now, this test, it confirms that the TSH measurement, is it matching the, whether it is, if it is high, then obviously the free T4 levels will be low in case of primary hypothyroidism. Whereas in patients who are suffering from, say, suppose autoimmune disease of thyroid, the autoimmune disease of the thyroid is detected by measuring the antibodies against the thyroperoxidase enzyme. Antibodies against the thyroperoxidase enzyme. Example of this disorder is Hashimoto's thyroiditis. Hashimoto thyroiditis is an autoimmune disorder wherein the person is suffering from antibodies against the thyroperoxidase enzyme, anti-TPO antibodies. And Graves' disease, that is hyperthyroidism. Graves' disease also, if the patient presents with hyperthyroidism, then it is Graves' disease. Hyperthyroidism with anti-TPO antibodies. Anti-TPO antibodies are high. It means patient is having either of these, either Hashimoto's or Graves. If patient presents with hypothyroidism, you can call it Hashimoto's. If patient presents with hyperthyroidism, you call it Graves' disease, right? Additional antibodies like thyroglobulin antibodies and other antibodies can also be present in thyroid. TSH receptor antibodies can also be present. We call it long-acting thyroid stimulators. The TSH receptor antibodies, which are common in Graves' disease, are easily detectable, but very rarely you tend to get such patients. Some patients have got problem in iodine uptake, and such patients can be detected by the radioiodine tests, nuclear medicine. Radioiodine tracer techniques. So increased uptake means patient has got more and more iodine uptake, resulting in more and more thyroid production, hyperthyroidism, Graves' disease. And say suppose patient has got certain adenomas. Whether that adenoma, say suppose this is the thyroid gland, and in the thyroid gland patient has got, say suppose a part is adenomatous, lot of big adenoma is present. If in this adenoma you find that the radioiodine take up very high, you call it toxic nodule, toxic adenoma. Alright, its activity is high. If it is showing less activity, you call it cold nodule, or you call it solitary thyroid nodule, and treatment of solitary thyroid nodule should be carried out. So this is all about the diseases of the thyroid gland. And we will discuss much more aspect of diseases in clinical medicine topic. But please remember that whenever a patient comes to you, it's very common disorder, and whenever a patient comes to you with this disorder, you should be able to explain to the patient. What is the level of disease he has, and what are the important functions of thyroid hormone, and the importance of replacing with thyroid medicines. All right, whether to treat hyperthyroidism or hypothyroidism and all. I'll discuss that everything later on when I'll be discussing general medicine, right? To summarize, I told you in the beginning of my class, I told you that we shall be discussing the calcium metabolism. Will, in a nutshell, we try to summarize the calcium metabolism very quickly, because I find it to be a very important topic, that is regulation of calcium metabolism. How does it occur? First we talked about the pyroth hormone, is it not? So my topic of thyroid gland is complete now. I am discussing a revision of my last class in a different manner, so that we understand our last class also better. My aim is you understand this calcium metabolism in such a way that you don't tend to miss any question from this area, especially in your exams, and also you pick up the patient in your clinic with the disorders if they come with. All right, so what is the overall stimulus for secretion of parathormone? It is a low calcium. So the stimulus for secretion of parathormone is a low calcium, low serum calcium in the circulation. What are the actions of parathormone? What are the important physiological actions of parathormone? If you remember, the actions we can divide it into action on the bone, action on the kidney, and action on the intestine. Bone, kidney, and intestine. All right. So on the bone, it increases resorption, is it not? By increasing the activity of the rank ligand, it increases the bone resorption. On the kidneys, the most important step is it increases the calcium resorption, calcium absorption or reabsorption. From where? If you remember, I told you, from the distal convoluted tubule of the nephron. It increases the it decreases the phosphate reabsorption. I'll write this with another color so that you remember it properly. It decreases the phosphate reabsorption. From where? From the proximal convoluted tubule. Please remember that in this process, the body has to excrete more cyclic AMP. So if you see, urinary levels of cyclic AMP increase. Urinary levels of cyclic AMP, because cyclic AMP is a second messenger of parathormone. Second messenger of parathormone. In my first class of endocrinology, I told you how important the second messengers are. Parathormone is a protein bound hormone or a water soluble hormone. It has got cell membrane receptors. Cell membrane receptor, if it is present, it acts via the secondary messenger system, that is cyclic AMP, IP3DAG, all those pathways I explained. So here parathormone is acting via the cyclic AMP mechanism. Hence the urinary levels of cyclic AMP are increased. Urinary levels of cyclic AMP are increased. So we are quickly revising how are these hormones, what are the actions of these hormones, right? We compare it with vitamin D. On the intestine, what is the action of parathormone? Obviously, on the intestine, it increases the calcium reabsorption. On the intestine, it is increasing the calcium reabsorption, right? On the intestine, it is increasing the calcium reabsorption. So, what is the overall effect of parathormone? What is the overall effect of parathormone? Overall effect is increased calcium, decrease phosphate from the body, from the serum. Increase calcium and decrease phosphate from the serum, is it not? Now let us come down to comparison with vitamin D. Vitamin D. What is the stimulus for secretion of vitamin D? Stimulus for secretion of vitamin D is low calcium, same like parathormone. Stimulus for secretion of vitamin D is low serum phosphate. Stimulus for secretion of vitamin D is high parathormone. All right, these 3 points you have to remember. What are the actions of vitamin D on the bone, on the kidney, and on the intestine? On the bone, vitamin D increases resorption. Resorption means increased activity of osteoclast comparatively with when compared to the osteoblast. Next is increase in calcium reabsorption from the kidneys. Increase in the calcium reabsorption. Increase in the phosphate reabsorption also. And write with some other color. increase in the phosphate reabsorption. Increase in the phosphate reabsorption, increase in the calcium reabsorption. In the intestine, again it increases the calcium reabsorption by what protein? Yesterday I told you, cal binding protein. Cal binding D28, K, something like that protein is there. Because of action of this protein, the vitamin D increases the calcium reabsorption from the intestine. It also increases the phosphate reabsorption from the intestine. What are the overall effect of vitamin D? What are the overall effect of vitamin D on calcium and phosphorus? Because it is increasing the absorption of calcium everywhere, it increases the calcium. Because it increases the phosphate reabsorption everywhere, it is overall effect is it increasing the phosphate, serum phosphate levels. Apart from this, the third important hormone that we read on that day was calcitonin. Calcitonin, what is the important stimulus? It is the increase in calcium. It's a surprising point. For all other hormones, if you see, decrease in serum calcium was a stimulus. But in case of calcitonin, it is the increase in serum calcium which is the important parameter to stimulate the secretion. What is the function of calcitonin? It decreases reabsorption, bone resorption. Does calcitonin have any effect on the kidneys? No. Does calcitonin has any effect on the intestines? Does calcitonin has any effect on the intestine? No. All right, please remember these 2 points. These 2 points are very, very important. So overall effect of calcitonin. Overall effect of calcitonin is to decrease serum calcium, but no effect on the phosphate. Vitamin D overall effect is to increase calcium and phosphate. Parathormone overall effect is to increase the serum calcium and decrease the serum phosphate. We all know that parathormone secretion is because of low levels of serum calcium. How is it? With the help of a receptor called as calcium sensing receptor. All these points I told you in my last video, so I'm just revising it. What are the important actions? I already discussed parathormone. In the renal, the proximal convoluted tubule, there is a excretion of phosphate. We call it phosphaturia, phosphoturic effect. Because of this phosphoturic effect, phosphate reabsorbed from the bone is excreted in the urine, and this helps in ionized calcium to increase. Serum ionized calcium increases actually. Cyclic AMP, which is generated as a result of action of parathormone in the proximal tubule, is excreted. Hence urinary cyclic AMP levels are very, very high. In a disorder of increased parathormone, obviously if you want to check it, you can cross check it with levels of urinary cyclic AMP, and the parathormone hyperparathyroidism can be detected like that. So what are the important effects of primary hyperparathyroidism? Last class I told you it is because of parathyroid adenoma. Serum calcium increases, serum phosphate decreases, urinary phosphate excretion increases, urinary cyclic AMP levels increase, urinary calcium excretion also increased because of increased calcium load to the kidneys, and increased bone resorption. These are the important effects of parathormone hyperparathyroidism. All right. What are the important effects of hypercalcemia of malignancy? Because of parathyroid related peptide, what happens is there is increased serum calcium, decreased serum phosphate, same as primary hyperthyroidism, increased phosphate reabsorption, but the serum levels of PTH, the serum levels of parathormone are low. But the serum levels of parathormone are low, you call it hypercalcemia of malignancy. It is because of parathormone related peptide. All these points already I told you in my last class, just I'm revising it. Chronic renal failure also affects the absorption of calcium. Chronic renal failure results in increased serum phosphate. Increased serum phosphate. Phosphate retention is a big problem, big issue in chronic renal failure because of decreased GFR. Decreased GFR, especially what happens is there is less excretion of phosphate. So increased serum phosphate. and decreased calcium is decreased. Calcium levels are decreased and phosphate levels are increasing. Decreased calcium causes secondary hyperparathyroidism. You call it osteogenesis osteitis deformans. I told you this point also. Osteitis deformans, that is renal osteodystrophy. And we have various other disorders of hypoparathyroidism. We already discussed it. So this class comes to an end here. In my next class, which will be very interesting about growth hormone. After that, we'll be discussing sex hormones, and thus we will be completing the topic of endocrinology in 2 classes, maybe next 2 or 3 classes max. All right. So thank you very much for patient listening. Any doubts, please get back to me in the chat or through the email. All right. I will be very happy to help you in your doubts. Thank you so much. Uh-huh.